Okay. Well, welcome everyone to our first town hall discussion about research and the Black families and communities in the Kansas City area. Many of you may have attended the Thursday, June 17th kickoff session for the national conversation, and we thought it would be good to have a local conversation. So as you noted, we are recording this. If you would prefer not to be recorded, please feel free to leave, but I will tell you that we are recording this in order to share the information with our KU Cancer Center Clinical Trial Office. They had specifically wanted to get additional information. The format for tonight is we'll start out with Jill Peltzer, a nurse researcher from KU School of Nursing and a friend of Pivot, and she will share a little bit about the previous presentation. And then Broderick, Crawford, and Crystal Lumpkins will facilitate a conversation. And this really is about a conversation. And so we're hoping that you all will participate in it as well as learn a little bit and help us learn as well. So with that, it's my pleasure to hand the baton off to Jill to kick off the presentation. Thank you.
Great. Thank you very much, Hope. I am going to share my screen. I took some notes from the panel discussion that I wanted to share. So welcome, everyone. I'm thrilled to be here with you this evening and talk about cancer during the inaugural National Black Family Cancer Awareness Week. The FDA Oncology Center of Excellence launched this inaugural National Black Family Cancer Awareness Week in accordance with the very first presidential executive order that was signed to advance racial equity and support for underserved communities through the federal government. And they chose June with intention to align with Juneteenth, particularly in hope that the time of launching this, that Juneteenth would be established as a national holiday, and it has been. And also with Men's Health Month and National Cancer Survivor Day. One of the polls that they did during the panel was about, when polled, what do you think is the number one reason African Americans don't participate in clinical trials? And 59% of those who participated said that past unethical treatment and influenced decisions to participate in clinical trials. And 39% said that African Americans are not asked to participate in clinical trials. So I think this really emphasizes the rest of the panel discussion that I think is particularly important for our clinicians, researchers, clinical trial office team, and the rest of our KUMC community. We need to do a better job of identifying, recognizing, and addressing the barriers that impact African American families in deciding and having the option to participate in clinical trials. So here are some of the key takeaways that I took from the panel. Okay, there, sorry. One, community involvement is critical to building education and prevention approaches that will be effective. And one of the panelists provided a really great example that if we were interested in providing education to Latinas about cervical cancer prevention, that there might be messaging where there's 4 generations of women in the kitchen talking about reasons for cervical cancer and ways that that we know are effective in preventing. So context is really important, and we need to involve community to build appropriate education and prevention approaches. Yeah, they also talked about science as bilingual, and scientists do not do a good job translating for the public. I think these are conversations that are not new to those of us who are here this evening. We know that there is a tremendous gap in how we are disseminating information, to whom we're disseminating information, and the language that we're using. And we need to do a better job of learning how to communicate. And we can partner with our community advocates so that we can learn from them the best methods of translating and disseminating information to the community. Academic centers are often located in communities that have been historically overlooked, yet have a low percentage of racially and ethnically participation in clinical trials, and in particular in early phase clinical trials. So again, more for our medical center colleagues who are on the call this evening, what are ways that we can ensure participation? How do we make sure that individuals can access care in the health system? And then how are we engaging them in conversations about clinical trials? The key takeaway that I heard over and over again was that we have to invest in the community. And this, again, is not new for those of us who are on the call this evening. But we hear from community members when scientists don't have a grant, they're gone. So we come in and complete a project over a couple of years, and then we leave. We need to invest in the community. We need different models that can be used to maintain consistent presence in the community. We need to look at different funding mechanisms that can help us maintain consistent presence in the community, so that we're not project-based and temporary. We also need to make sure that we are trained by the community in how to be effective community partners. We can't assume that we know how to engage in the community. And so it really takes a collaborative partnership where we have bi-directional education and training. We can provide education about research and health system, and then we can learn about how to be good community members with our other community organizations. And scientists need to be dutiful in translating science to local policy. So we can't stop at completing a project and even translating to the clinical setting. How do we translate science to positively impact local policy in collaboration with leaders and community members? Those were my key takeaways. I will be interested to hear from Crystal and Broderick, maybe some of the key takeaways that they have from the panel. And now I'm going to turn it over to Crystal and Broderick to share their perspectives. I'm sorry, I jumped ahead. I forgot I had another slide. The onus is on physicians and other health professionals to engage patients in discussions about clinical trials. So I've kind of moved from how we need to be in the community to once we're in the healthcare setting. So physicians and other health professionals need to provide the opportunity for individuals to participate in clinical trials, use culturally informed strategies to provide information about clinical trials, and to ensure that patients are able to make informed decisions about clinical trials. So now we are ready to open up the conversation. So Crystal and Broderick, I'm going to turn it over to you. I think you were going to tag team on answering these 4 questions and then ask our audience.
Absolutely. So Jill, thank you again for your summary and the presentation that you have provided. Thank you again to Hope and Sarah for all that you do with Pivot. It is certainly an honor for me to be with you all here tonight. Yes, Crystal and I are going to address each of these 4 questions, but I think before we do that, let me just say that I think a lot of the information that has been provided via the national conversation doesn't always hit home. And I'm hoping, and I want to share with our audience, that we want this to be a conversation, not just Crystal and I talking about our perspectives and opinions. What we certainly want to hear from you. We want to hear your thoughts, your concerns, and in many ways, it's feedback and advice. So that being said, Crystal, the mic is yours.
Well, thank you, Broderick. As Broderick said, I really appreciate being a part of this conversation. And thank you to Sarah, Jill, and Hope for this opportunity. This national discussion is only what I say, the starting point. And so it was really good. I thought it was a very robust discussion. But as we know, in 90 minutes, you can't cover everything. But saying that, I think this is an excellent platform for us to dig down deeper and to see how we can take this national discussion and apply it here locally and even regionally. So the first question that you see here is, what surprised you, if anything, from the national discussion? And so I know, Broderick, I just wanted to ask you so that we can just start the ball rolling here. Were there any things that surprised you about the national discussion?
So Crystal, I would say that not necessarily anything quote unquote surprising. I mean, most of the information that was presented, we already knew. It is very clear, is very factual that people of color have not participated in a way that is often meaningful. It's often in participation when you think about some of the tragedies and things that have happened as it relates to folks of color with clinical trials and with cancer for that matter. The other piece that I would say that often is not often touched on is, yes, we want to have a discussion, but rather than just a discussion, I have a preference of seeing action. And so I did not see anything laid out as to what individuals actually could do. So what are the tasks? What are we going to do next? What are the next steps that we need to do to not change the conversation, but change the activity? Because that's what needs to change. The activity needs to change. So we know, for example, that African-American women have the worst breast cancer rates and mortalities and all of those things. So what are we going to do about it? Are we going to continue to talk, or are we going to put some action in place? We know that prostate cancer, by and large, affects African-American men more negatively than their white counterparts. So we're going to keep talking, or we're going to do something. So again, those are my initial comments, and certainly we would invite the audience to weigh in. You can either raise your hand or just take yourself off mute, but we certainly want to hear some feedback from you all about the cancer conversation on a national level.
So thank you, Broderick, for those comments. And as we are waiting for those comments or questions to come in, I will also add in this, that while you were commenting so rightly about just the actionable steps, I was also looking at the social determinants of health, because that's, as a researcher, that's some of the things that when I'm looking at barriers, and what Jill mentioned is how someone mentioned on the call that they mentioned steps, getting in the steps, the 20,000 steps or 10,000 steps, but maybe someone doesn't have access, or as far as even being able to walk, those types of things. And so those were some of the things that came to mind. How do we arm people or equip people to make actionable changes? So great. I think I saw something. Was there a comment?
Yes,
okay.
Pastor Carter. And actually, Pastor Carter, you did put a comment in the chat. I'd like for you to go ahead and bring yourself off mute and tell us why that's a concern for of yours.
Well, Broderick, I think you drove the point home. I was just kind of dittoing what you were saying. If we don't propose action steps to go with the information that we are already all aware of, if we don't come up with some step 1, step 2, step 3, whatever, some actionable items, then we're going to keep having this conversation every 10 or 15 years, or every time some kind of health crisis comes up, and it's just going to continue to illuminate that there have not been any really actionable steps taken to begin, and we're not going to eradicate it overnight, but to at least begin the process of decreasing those things that we know. And so the action steps, or at least a recommendation, let's start here. And there were no action items or recommendations included.
And one of the things I saw, we'll get to this question that has come up about how do researchers typically recruit patients. But one of the things I just wanted to piggyback off of what you just said, Pastor Carter and Broderick, as far as those actionable steps. And what I think was reflected in the national discussion was community involvement. I know we say community involvement, community engagement, but are we truly involving those people? And that's why, again, this is what my view as far as being a community-based participatory researcher, that many times researchers are engaging with the community, but is coming from a top-down approach. And it's not truly including those community members or those patients, for that matter, in all phases of the process. And so you have this where people are engaging, the community, and it's coming from the perspective of the researcher. And we see these things, essentially this cycle that is repeating. So Broderick, I wanted to make sure I give you an opportunity to respond as well.
Well, yeah, absolutely. And I definitely want to respond to Alex's question about how patients are recruited. And so oftentimes, if there is no real connection to the community, the recruitment is not where it needs to be. There are many cases where clinical trials currently fail to meet their minority recruitment numbers because they don't have access or they don't have relationships. So oftentimes, as you know, as we here at Pivot have worked with our researchers to become more engaged in the community outside of what they need for a particular clinical trial or project. So how are you engaging with the very folks that you want to do research with? Do you know where their families live? Do you know where they go to church? Do you know where they go to the grocery store, if they have a grocery store? So for example, in many of our communities, there are food deserts. Are you aware of these other social determinants that occur in the day-to-day lives of these proposed or potential patients for your trial when you don't have any engagement with them? And I think that's a problem, because without relationship, folks are not going to want to engage with you. You can, in many cases, offer money or other different types of incentives, but unless it's something that's, I'm on my deathbed, I really don't want to hear what you're saying, or I don't want to participate because I don't have a relationship with you. And so in many cases, what often occurs is researchers will reach out to folks like many of the folks on this call today. So Angela Williams, Dola, Christine Darnell, Pastor Carter, Tanya, and so they'll look for folks like that to try to connect to the community. But even with that, if you still haven't developed a relationship with me, I'm not necessarily going to be all huggy with you, like kumbaya, because why do you need me now? And then the second piece of that is, even when you want to connect with me, how do you identify community? In many of our academic institutions, community is identified by the folks that work at the institution and not folks that are actually living in the community. There was a slide that talked about many of our academic institutions in the communities that are the most impoverished. So for example, KU is in Wyandotte County, which has had one of the worst health rankings in the state of Kansas since 2008. I love most of my KU colleagues and researchers, but what has KU said that they're going to do to change that? What is the public announcement from leadership at KU to say, this is a travesty and we want to do something about it? Women in Kansas have had breast cancer in the worst rates for years. It's just now that all of a sudden we want to do something about it. And so it's those kinds of activities, and I'm going to shut up because you can tell I can get a little passionate about this, but it makes no sense to me. It makes no sense why we continue to placate one another. Oh, yes, we're doing this, and oh, yes, we're doing that. But yet the rates are still staying the same or getting worse.
Absolutely. And Broderick, you raised, some very important points, and it is the relationship building. And I will say with my experience, when I first started, the research with African Americans, you can see I'm African American in the community, was very much so when I went out trying to start building relationships, it was hard, it was difficult because of previous times where researchers had gone into the community, said I had to do a research project, and they're gone. It only lasted the grant, the life of the grant. And so we know it's very important for like pivot, training, and having those relationships, building those relationships where there is a common and shared interest, because we're in the dot, and we have a true investment in Wyandotte County. And so I know that everyone has heard this expression, I believe, that it's not just a sprint, it's a journey. And so it is, the time and investment is so key. And as a former journalist, I remember, so I promise I'm not going off on a tangent here, but when reaching out to individuals about what is in it for me. And so I think all of us, we have to look at, researchers, we're in this so that that we're trying to address these cancer disparities, and then community members, patients, there's a desperate need to address these gaps in health disparities. And so I think there was also another, yes.
Yeah, there's a couple of comments. So one, I want to respond to Dr. Jensen, who is our fearless leader, who without him, we would not be able to do the things that we do. And so we want to appreciate and applaud the efforts that Dr. Jensen has done with the Cancer Center. But then he spoke about FaithWorks, which is an organization you and I might have a little relationship with.
Yes.
But even when FaithWorks was initially formed, you as a researcher, it took you, if I'm not mistaken, 2-3 years before even yourself as an African-American researcher really had to get to the position that you have today.
Yes.
And then Mary Green made a comment. I want to ask her to unmic and share a little bit about her concern that she shared in the chat. Mary?
Good evening, everyone. My concern is this: often African Americans do not participate in research because of their past treatment by those in medical fields, such as pharmacists, doctors, or other researchers who have came into the community and mainly used us as guinea pigs and then left. And there is no follow through, or they have been mistreated or talked to like they should be glad to get this. And that's the wrong way to come off to people. And truthfully, I'm interested in all the help we can get, but totally I don't trust researchers or some doctors because of how I've seen them give wrong medication to people, and they know it. I just had an experience where medication was given to me to cure one thing, and but for some reason I never went and got it, or they didn't give me the prescription in my hand. Then later I get a message from my insurance company that said this medication is not even recommended by the FDA, and it's highly poisonous to seniors and should not be used. But then the doctor's office called and asked me, was I taking the medicine? I said, no, I got bad information on it and my insurance company will not pay for it. And their response was, well, that's okay. It's not that high. You could pay for it. These are the things that happens to make the wave of a red flag for people of African American descent, because we're trying to figure, do you really care? Do you want me to get help? Are you going to think enough of my participation to pursue steps that's going to help me help communicate with other African Americans that there is help out there and that we could beat this if we do this? I just don't want you coming in, doing an experiment and leaving, you know? And so for me as a whole, you say medication, participating in research, and a flag goes up because I'm wondering exactly what is the hidden reason for the research. And I think until we're able to communicate to people exactly what we're doing and not make this a project that lasts 6 weeks or 12 weeks and run away and not follow through, you will not have a lot of African Americans participating.
So
That is so awesome. Yes, go ahead. Someone else wanted to speak. Yes.
Oh, first I want to say I am sorry that that has happened to you, Elder Green, that you have experienced that. I'm not sure where that occurred, but what I will say is that at KU, we are very intentional about addressing those things. And myself as a researcher and have engaged with the community, really need individuals like you to be in those, in the capacity of addressing things such as that. And so those experiences are real. And, unfortunately, some of these things have occurred, but should not be occurring. Because one of the poll I saw as far as unethical treatments and those types of things, these have been things that have been perpetuated and compounded. And a lot of the good things that are happening, it seems that those have been pushed aside. So what am I saying? I am saying that the process that I'm involved in is being very transparent, and hoping that if there are certain, you talked about medication, I think that you were put on or so forth, and again, I can't speak to specifically your specific your process that you went through, but there should have been something in place where you were informed, and so that's very unfortunate. But Broderick, I don't know if you had any other.
No, I don't have anything else, but there's another comment. And again, what you will see me do is I'm going to, since I know a good majority of the folks on this call, I'm going to speak, continue to call folks out. So Dola, you put a comment in the chat. So I'd like for you to unmic and give some insight on your comment and why you feel the way that you do.
So I think, go back to what I said, but I think so. The challenge is, or one of the challenges is, I know that there is a patient navigator, and this is as related to breast cancer. There's a patient navigator at the Unified Government Health Department, but there is a disconnect between the work that she does, in my opinion, and the work that has been done with KU. Like there's not or I have not seen or been able to engage people to partner with what is going on there. I also think that the people that she serves are mostly uninsured, I think. And so they are not in spaces like this, and probably more of the ones who are affected by not having access, right? That's what we're talking about, to the different services that are available. And so the very people we're talking about are not at the table at the community level. And then the people who are providing the services are not even talking to each other. So, you know, there's that. That's one challenge that I think is a big challenge.
Thank you so much, Dola. And I think you're absolutely correct. And I think Hope has already indicated she wants to reach out to you to get, you know, a little more insight and information. Connecting the dots, as we say here in the dot, is so very important. And when you have all of the different entities, I share with my great KU colleagues that community doesn't understand that there's a hospital system, that there's a cancer system, that there's a med center system, that there's a nursing system, there's a health professional system. All community hears is KU. Or there's a system in Lawrence, or there's a system in Wichita. KU is KU. And so how do we better connect the dots, not only internally at KU, but then how do we communicate that? I work very closely with a good friend of mine, Ryan Spalding, and how are we changing the narrative with what's being said and what's understood about KU in this community? And those are things that are important questions, because people, again, the person, and I'm pointing right up the street on 7th in Minnesota, when you say KU, it's going to be one KU. It's not going to be 4 or 5 different entities. And I'm going to ask another friend of mine, Tanya, if she would weigh in on that particular perspective.
So what you're saying is having the different systems, you mean, Broderick?
Yes, yes.
Okay, so right, you're exactly right. They're KU, one system, but there are many different broken out divisions within that system that people don't, you know, unless you have cancer, you're not really concerned about the cancer center or the, you know, certain things in the Well Women's Clinic and the other things. So I don't really know how to educate those people that have that don't have insurance, to tell them about some of the other things and some of the questions that they can ask. Maybe perhaps, I don't know how to connect them with different systems other than a navigator. But what I can say is questionnaires, asking them things, you know, when they check in, if they would be interested in this or that, or are they aware of this, or do they have any questions? And so while they're sitting and waiting, maybe perhaps doing a little bit of that to kind of help them along in the process to see things that they can't naturally see.
Thank you so much, Tanya, and I appreciate your input. And again, this is what we need. We need input from the community. So Crystal, I'll turn it back over to you and let you take us to the next question, if you will.
I have a quick comment, Broderick.
Oh, absolutely, Dr. Solano, please do.
Okay, something being in the recruiting side, something that just caught my attention and is one of the findings that surprised me is that the incentives, that we are using incentives to recruit them. And many of the people that we work with, they ask me, okay, if you're giving me something, if you're paying me to do this, it's because I am at risk. So there is an implicit, and it's an interesting finding. And now same thing is happening with the testing, and same thing is happening with the vaccine. If you are giving me so many incentives, what is the risk? You know, what is what you're not telling me? Because and the higher the reward and the higher the incentive, the more, let's say, paranoid the people become. And it has been an interesting finding, even though we use words as compensating you for your time, it's a compensation. It is interesting, the perception that we are buying something. So just a comment.
No, yes, thank you. And actually, Broderick and I have actually, you know, we're on another research team. together and we've talked about some of these things. And so, you know, this incentivizing behavior, and, you know, what, again, Broderick, you may have another comment here about this, but I think when we look at that, compensation for the testing or the screening, that it should be something that would, an individual could naturally, that would be helpful, such as covering the cost of, you know, the screening, not something such as, you know, and again, this may be a little bit not exaggerated, but thousands of dollars, for instance. But if it's a clinical trial, that's something different. And so this is something, yes, that we are actually, you know, this conversation, as you know, this the COVID-19 situation where there are tuition dollars and those types of things. So,
well, and Crystal, I can share if you don't mind. So right now, I've been asked to join a team here locally that is going to now begin to recruit individuals that are not vaccinated, that are of minority, and are between 18 and 29. So again, the whole incentive question that Manuel brought up is very key. So how do we appropriately compensate folks for their time, but yet not getting them to the point where they're reaching, okay, why are you throwing whatever this X number of dollars at me just to do this for something I already have an issue with?
Right.
And so that conversation is absolutely needed. And actually, as we start this trial, which is actually going to be here in a few days, I will be reaching out to several of you for your input. Chris, if you don't mind, I think we have two other comments in the chat that we should probably go to. So Dee Potts has put something in, and we certainly want to give her the opportunity, and then Angela Williams. So we'll go to Dee first, and then Angela.
Hello, everyone. I'm glad to be able to be here this evening. The Black Fam Cam initiative was really interesting to me. It was very good to see so many African-American doctors on the panel and all over the country, and hearing their the things that they have done and the research that they've done. A couple of things stood out to me from the first half of their discussion that I think are some things that kind of is going to touch on the next question. So forgive me for—
No, go right ahead. Go right ahead. This is open discussion. Yes, please do.
Okay. Some things that I think we could implement here in our area. One of the panel members was a retired professional sports player. And he was saying how using the people in professional sports to put out different messages and things like that to the community was one of the ways that they were able to help people get involved in clinical trials and some screenings. And so, you know, we've got the Royals, we've got Chiefs Kingdom. You know, maybe there's something we could do to help partnership with them to help reach, you know, a different niche in the community with people to help them to see the benefits of clinical trials and some screenings that can be done. One of the other things that I thought was very interesting was talking about the bilingual science. That was something that, what is her name? Jill, that brought out at the beginning in her PowerPoint. And so they actually brought in community members to work with doctors to train the doctors on how to communicate with people in the community, rather than being the other way around. Because a lot of times, it's something we talk about in Pivot all the time, you know, scientists, researchers, doctors, sometimes they can get in that language that's just, you know, over our head, you know, and so it makes it difficult and challenging to really help people understand what they're actually getting involved in. And so I think that is an initiative, is something that we could start, just two very practical things that I think that we could definitely start off in. And then I wrote later in the chat, yes, relationships, about the Susan Komen program. So when I was diagnosed, I was uninsured. And so I was living in Wichita at the time, but I went to the health department And they signed me up with the Susan Komen breast cancer and ovarian cancer screening program, and it was covered for free. And so I don't know, then from that point, there were some, my file was flagged, and that sent me to different, the cancer center there in Wichita, and also a particular breast surgeon that was there in Wichita that all worked with uninsured people. And so it's something in their, system where they have it set up to where uninsured people get directed, in the right places so that they can still get good care. I had the top surgeon and also one of the top cancer doctors in the area, even though I was uninsured. So that's something that we could look into as well. Those programs are really good. Somebody talked, the early detection works. That was the program that I was able to get my screening through.
It's outstanding. That is great information. Absolutely. Angela.
I do. Can I just say something
Sure.
just in response to Dee? So thank you so much for those. And I'll just quickly say that I know that our communication marketing has done some collaboration with Royals Chiefs. And in fact, I was just at Topgolf yesterday and I saw the KU, there was a sticker on the table. But what you're saying though is that clinical trial piece. So I think that is excellent. So thank you. And also for sharing your experiences too. So Angela.
So that's a good something to put a pin in. So Dr. Crystal Lumpkins at Topgolf.
Yes.
All right, Angela.
I talk about my score, but that's okay.
No, it was just in follow-up to one of the questions that was asked earlier, something that you heard or you didn't know. I may be misquoting, but in attending the meeting, I was listening and I didn't know that I guess for me is messaging and what you hear and the intent of what was said. And so when it was said that you would get better treatment or higher quality of care if you were seeing a doctor that is connected to a clinical trial. I heard that. Yes, I mean, on Friday when they were speaking, and I'm saying, how does one know to go in and ask that question? Not to say that if the doctor is not involved in a clinical trial, you won't get great care, but it takes you back to would my outcome or my circumstances be different if I was with a doctor that was involved in a clinical trial?
So I'm going to ask either Dr. Jansen or Hope to respond to that, either one of you.
And then I got another part too, but go ahead.
Sure.
Sure. So thanks, Broderick, and thanks, Ms. Williams, for that question. I think that statement comes from studies which have shown that patients that are enrolled on clinical trials, even if they don't get the new treatment, the new drug, or whatever, actually turn out to have better outcomes than patients in the community that are receiving the same standard of care that they're getting. And that may seem a little puzzling, but the reason for that is that when a patient is enrolled in a clinical trial, it's one of the it's a way to basically guarantee that you are absolutely getting the known standard of care at the time, and that there's no alteration in that standard of care, because there's all kinds of people that are checking to make sure that say like if Mrs. Smith missed her appointment on Thursday, somebody is calling her up and finding out what the issues are and trying to make sure that she stays on track in terms of her next chemotherapy or next X-ray exam or something like that. So I think most of that just relates to that. And then, the other part is that it is quite likely that a physician that is participating actively in clinical trials for their patients is very much up to speed on kind of what the latest therapeutic approaches are, and that they're very invested and interested in keeping up with the literature. And, they're not just practicing kind of the same way that they were practicing, 3 to 5 years ago.
So Dr. Jensen, would a person who is not in a clinical trial still get that same type of care?
So,
Well, potentially, but like the first point I was making is that a clinical trial, even for patients that don't get the new therapy, is such a rigid process that it ensures that you're getting the absolute known standard of care at the time. And like, it's not just like one physician who's trying to keep track of that. It's that physician plus the research nurse, plus the data coordinator, because they're all monitoring and making sure that, everybody's making their appointment and getting the therapy that is prescribed in the trial. So it's like a whole bunch of people kind of checking on one another and making sure that everything gets done.
So in that case, Dr. Jensen, when you have the clinical trial physician versus the non-clinical trial, the clinical trial physician has more hands on deck, if you will, to make sure that they're tracking and following, where a regular PCP not in a clinical trial is subject to what he has available in his or her office. Is that fair?
Yeah, I think that's an appropriate point to make, Broderick, in that physicians that have access to clinical trials generally have a more kind of supportive infrastructure to help them manage the patients. And, it just, that just makes sense. So, I think that's where that comes from.
Awesome. Hope, it looks like you wanted to respond. Please do.
I would love just to add in, I think that second point that Dr. Jensen also made about really being up to date. We often hear from our Masonic Cancer Alliance physicians who say that participating in clinical trials makes them a better physician every day. And so one of the things that Dr. Jensen mentioned was that you have the people getting the new treatment or the old treatment plus something new. I mean, it depends on the trial. And you have what we consider the standard of care. That's what they're comparing it to someone who's getting the standard of care. So those doctors have to read what the standard of care is and follow that to the T. And so they read it every day. And so even if a patient doesn't get involved in the trial, that doctor remembers what that standard of care is because they've read it in the clinical trial and they have to follow it with other patients. To your question also, Angela, how do you find a doctor involved in a clinical trial? Some of the ways that I do that is for friends or family who don't live in Kansas City but are wanting care. I look on the websites of those locations and I look to see if they're partnering with a clinical trial network of some kind, or if they're partnering with an academic medical center. If it is an academic medical center, more than likely their office is participating in trials. But to really know whether or not that physician is participating in trial gets a little harder to find. And I could describe some ways, but it's a lot harder to find. And it may mean calling and asking the office. And it's okay as healthcare consumers, we are investing in our care, and we have the right to call and ask and even interview the staff about those sort of things prior to making the appointment.
Yeah, but what I was, and I appreciate that, Hope, but I guess I was kind of thinking, prior to me participating in that webinar, how does one know to even ask that
They
question?
don't, right? Yeah, like,
You
right,
know,
it's not even in the head, right?
Right, like I've shared with several of you before, my husband is an 8-year bladder cancer survivor. I've never even thought to even ask that question. We just went along with what the doctor was saying. Now, by the grace, he's well, but I didn't know. So how do you know all that? How would one, the average person just know to do that if they're not involved in the system?
And
So this is Peggy Johnson. Boy, she's hit it on the head, that there simply has to be more education about clinical trials. My first question to my oncologist was, is there a clinical trial for my kind of breast cancer? And he, at that point, had already looked and knew that there wasn't. But there has to be more public education. And I know KU's trying to do this, but we among ourselves and in our communities have to be telling people what clinical trials are and exactly how Dr. Jensen explained it as to what the benefit's going to be. Even if you don't get the trial drug, you get better care. And so this is where we have to, as Hope said, we have to connect and educate what the resources are. And not all communities have clinical trials, have access to community, to clinical trials. But that's one of the things that we have to continue to just hit on, is ask about clinical trials, because our daughters someday may need care, and the care will be given better because somebody participated in a clinical trial. Pay it forward.
Thank you so much, Peggy. Appreciate your input and your insight and your experience. We love to hear from you. Tanya, you had your hand raised. You have a question or a comment?
Yes, I have more of a comment. And my comment was, when I first visited my oncologist and my chance of reoccurrence was a number that was unacceptable to me, and that's when I said, okay, this isn't going to work. So what else? How can we make that number smaller? And then I didn't even know what a clinical trial study was. That's when that conversation started, because I was so angry about the high number of life expectancy for myself. I said, no, wait a minute. Let's figure something else out. And they introduced a clinical trial study. I had no idea what a clinical originally, I didn't know what it was, but I was then put on one. And so I'm forever grateful that I was. That's my comment.
Outstanding. Thank you, Tanya. My good friend, Crystal, I think I'm gonna turn things back over to you.
okay, wow, we've been having a very rich discussion, 6:23. I know we have a few more questions, but because this is a community forum, Hope actually had an excellent question, as we're looking at these clinical trials. And as Peggy, you mentioned education. So, I think maybe there was a response to this. I'm trying to read the chat and also facilitate at the same time. But that's something that, we want to ask. How do we educate? I think I know where it is absolutely having advocates and individuals that are training us and are helping to educate and going into those spaces, such as, I work with faith-based communities and going to faith-based communities and having educational programs. In fact, I will say that's something I feel very fortunate that have been able to work with faith communities with, cancer-related genetic counseling and testing. And so that's something that, and we don't see this as, I wanted to say this to everyone, as the first conversation. We see this as hopefully a series of conversations that we're having with you, a very important entity for KU, for our community. In the last few minutes remaining, Broderick, we had 4 questions. I think we actually covered
Yeah,
some
I
of
think we've
them.
covered most of what we
Covered
wanted
most
to do.
of them.
Yeah, I think more important than questions is hearing feedback from our audience. And so
Yes.
Pastor Carter has his hand up. So Pastor Carter,
thank you.
please do.
Yes, thank you.
I guess all I want to say is, because I know this is not something we're going to fix next week, next month, or even next year. But can I offer a Joe Lunch Meat, Willie Sausage Head conclusion?
Don't come with none of those Mississippi analogies, sir.
No, but I say that because, I feel like of all of the people who are on here, I'm probably the least, equipped. Because you guys there are healthcare. I'm here because I pastor a church, but I care about, and I think we all do care about our communities. And what I see, and I think Kaya Thompson said it earlier, it's about relationships. Here's how we educate people. KU should encourage their doctors to, and I'm not saying this because I want people to come to my church. I know that's what it's going to sound like, but that's not what I'm saying. But I think KU should encourage its doctors, not just the ones who are doing clinical trials, but I mean just in a general sense, to become involved with churches in the communities where the disparities occur and build relationships with those people, because those people, should they see them on a fairly regular basis, will begin to, I think will be drawn more to them. There will be more trust built over it. One of the reasons I got to be a part of the Health Equity Task Force was because Dr. Alan Greiner came to my church prior to this even happening. I mean, 2 or 3 years ago. And we built a relationship. I knew him, he knew me. And so that was a trust. And when somebody said they wanted me to consider being on the task force, and they mentioned Dr. Greiner, because of our relationship, I began to do something that I didn't know anything about, because I trusted him. And because I knew my little brother, Broderick, he was a big part of this too. My little brother was there, and he was encouraging and about the things that we could begin to do for our communities. And I think the key is to people being involved in situations where they can build relationships beyond our normal concentric circle of contact. Everybody has those people we know, and those are people we hobnob with, but I think we ought to be willing to extend beyond that. As a pastor, I've put myself kind of out there, and I'm uncomfortable many times because I know what I don't know, and I know what I do know, which ain't very much. But I know I care about the community, and there are opportunities where I can speak and bring relevance to a situation. And I think that's what we all have to do. It's building relationships, and doctors from KU should just start being a part of what's going on in these communities of despair. And over time, a lot of these issues, even if the doctor is not a clinical doctor, if there's a doctor there, that doctor can introduce the clinical doctor to a church and say, here's a friend of mine who does great work, and they're doing a clinical trial. Anybody who has these issues, I really wish you would talk to. And because my trust in that doctor, I would listen to his friend.
That is so
small,
awesome.
But it starts.
Yes,
done.
sir. Yes, sir. That is so awesome. And we're about out of time. So I want to be mindful of our time. Crystal, I don't know if you want to have any last words, but I was going to swing it over to Hope for us to wrap up and then take it from there.
No, the only thing that I will say is that I am so appreciative of this conversation, and I can tell that everyone has a lot of passion around this. And so we want to keep engaged with you. And so hopefully, and there's been a lot of chatter in the chat. We've had a lot of resources that have been put into the chat. But again, just really appreciate the conversation and honored to be a part of the here tonight. So thank you, Broderick.
Oh, take us home, please, ma'am.
Well, Crystal and Broderick, thank you. This has been amazing. I learn something every single time I'm with both of you, and this, of course, is one of those great days. And to the audience, you all have been so gracious with your knowledge and really sharing information that I think can make a difference. And I'm hoping that you will continue this conversation with us. We will definitely continue to try to reach out to you. Join our Facebook Masonic Cancer Alliance Facebook page, where we will make announcements about these sort of opportunities to talk. I put my email address in the chat, so feel free to reach out to me and share additional information, or if you want to speak to anyone specifically, I'm happy to connect you. It was thrilling to see people from Phillipsburg, Kansas, with Sandy Kuhlman and the hospice director, to the Kickapoo Nation representative with Chris Darnell, and Tara Lynn from the physician from the clinical trial office, and most important, and in addition, all these people that have experience from Wichita, and that many of you now are in Kansas City. Of course, Peggy Johnson is from Wichita. So this really has been a statewide conversation. Dee, Tanya, Reverend Carter, all the Pivot members that have participated, thank you for joining us. And we hope that you have a wonderful evening. And together we can make a difference, and we can prove and give everyone the opportunity to have a equal health and healthy outcome. So thank you.
So Hope, I'm gonna ask one final thing. Again, thank you to all, but I see a lot of additional chatter in the chat. So there are requests for different individuals who want to connect with different people that's on this call. So I don't know, Sarah, if you could put together a list of all of the email addresses to send to everyone, so that those that want to reach out and touch and have further conversations on a one-on-one basis, so that they can do so. So we don't want to deny or negate that opportunity. If there, as you all know, I love to network, and so it does appear that there is some interest in folks networking. So if we could get everybody's emails, because everyone doesn't know how to capture all the chat stuff, and
Great
get that
idea.
to everyone so that we can connect folks appropriately.
Great idea. So please, before you leave, add your email in the chat box, and we'll be happy to reach out to you all. So have a wonderful evening, everyone.
So we want to
Thank
give
you.
everybody a moment to
Thank
do so
you.
before we disconnect. So yeah,
Yep.
give everyone an opportunity to do that.
Yep. Sarah will stay on, and I'll stay on, so, or whoever is in control.
Ashley's got she's got the
I will leave it open.
All right. Thank you all. Have a great
Thank
evening.
you.
Take care.
Great. Thank you. Bye. Thank you.
Thank you.